Good evening, everyone. Welcome to our Fireside Chat number 182. Today we will have Dr. Shetty, who will be taking us through acid-base disorders, simplified, a case-based approach. Before we start, I'd like to introduce Dr. Shetty, who is a highly accomplished nephrologist and with a rich academic and clinical background. He's trained at prestigious institutions such as KMC Manipal, KM Hospital, Mumbai, the University of Toronto, and Henry Ford Hospital in Detroit. Currently, he's serving as an Associate Director of Nephrology Fellowship Program at the Methodist Dallas Medical Center. He is also a Medical Director and founder of CKD Modality Options Clinic for DNA, that stands for Dallas Nephrology Associates. A leader in nephrology research, Dr. Shetty has been a site principal investigator for multiple studies, including the renowned IgA Applause study, and has authored over 25 peer-reviewed publications with more than 40 conference presentations. He holds expertise in peritoneal dialysis and calciphylaxis. As a certified physician executive, he is a sought-after speaker for major medical organizations, including the American Society of Nephrology and the National Kidney Foundation. Beyond nephrology, Dr. Shetty is deeply passionate about holistic medicine and wellness, having directed CME programs on these topics for many years. A survivor of cancer, he is also an author of books on cancer, on his cancer journey and health, including Hinduism Simplified and the Power of Infinity, Health, Well-being, and Anti-Cancer Lifestyle. A dedicated community leader, Dr. Shetty has served as past president of the Texas Indo-American Physician Society and the TIPS Charity Foundation in Clinic. He is also a long-time practitioner of yoga, incorporating his knowledge of the ancient practice into his approach to health and wellness. With that, Dr. Shetty, the floor is yours. Please go ahead.
Thank you, Lloyd. Thank you, Dr. Amir Ali. And thank you, Dr. Kech. And thank you, everybody, for attending and giving me this opportunity to share a few things I know. And reason I chose this topic is I used to find it very difficult. And it took several years, even after completing my training, have a simplified approach to acid-base disorders. So I would like to share that with you all. I was blessed with the opportunity to kind of associate with a few acid-base experts in Toronto, in Detroit, and as well as in Dallas. And I don't know if it was me or them, but over time it got simpler to me. Okay, so I'm going to talk about few very simple definitions and then talk about the approach that I follow, that I learned from these people. And then we're going to talk about few cases that you all will come across. So acid is substance that donates hydrogen ions, and base is something that accepts. So in other words, acid has more hydrogen ions and base has less. The type of acids that we deal with are carbonic acid, which is excreted by the lungs, and non-carbonic acids. Some of them are phosphoric acid and sulfuric acid. These combine with buffers and they are excreted by the kidneys. So low pH means acidemia, high pH means alkalemia. So alkalemia refers to pH and acidosis refers to the process that lowers pH. Same thing with alkalemia. If the pH is more than 7.4, we call it alkalemia. Whatever that process that increases the pH is called alkalosis. In other words, when I say acidemia, pH is always acidic, but they can also have alkalosis. The main process is going to be in the same direction as that of pH. So in other words, if there is acidemia, major disorder is going to be acidosis. In addition, they can have alkalosis. Similarly, if somebody is alkalemic, main process is going to be alkalosis, but they can also have acidosis in addition. Normal pH is 7.4. So normal PCO2 is 40 millimeters of mercury. Normal bicarbonate is 24 milligrams per liter. There is a range, but for all practical purposes, we are going to take these numbers as they are, the absolute numbers. So in metabolic disorder, it's the bicarbonate that goes up and down. If the bicarbonate goes down, it's metabolic acidosis. Bicarbonate is up, that is metabolic alkalosis. PCO2, if the patient is not breathing well, hypoventilating, the PCO2 is not expelled, so it's retained in the body. That causes respiratory acidosis. If somebody is hyperventilating, they breathe out carbon dioxide, and that causes respiratory alkalosis. So the approach is always look at the pH. If the pH is high, it's alkalemia, and the main process is going to be alkalosis. If the pH is low, it's acidemia, and the main process is going to be acidosis. The person has acidosis as the main disorder. Then look at the PCO2 and bicarbonate. If the PCO2 is high, that means respiratory acidosis. If the bicarbonate is low, it is metabolic acidosis. And if the pH is high and bicarbonate is high, it is metabolic alkalosis. If the pH is high and PCO2 is low, that is respiratory alkalosis. So if there is a respiratory problem, there will be metabolic compensation. And if there is a metabolic problem, there will be respiratory compensation. So one thing that does not happen in mixed disorder, you cannot get respiratory acidosis and respiratory alkalosis together because you cannot breathe fast and slow at the same time. The metabolic components are affected by kidneys and the gut mainly. That's why if one is wrong, other one can do something else. That's why you can have metabolic acidosis and metabolic alkalosis at the same time. This is a busy slide. I'll try to make it simple. In metabolic acidosis, bicarbonate goes down, and that makes the person breathe hard to compensate. And to calculate this compensation, there is a Winter's formula. Winter's formula is PCO2 bicarbonate times 1.5 plus 8 plus or minus 2. So in other words, the bicarbonate is 20. 20 times 1.5 is 30. 30 plus 8 is 38 plus or minus 2. So if the bicarbonate is 20, you expect the PCO2 to be between 36 and 40. Still simpler way to do this. This is something I learned in Toronto from Dr. Halperin. If bicarbonate goes down by 10, PCO2 comes down by 10. If the bicarbonate goes down from 24 to 14, you expect the PCO2 to go down from 40 to 30. This is the simplest equation you can get. Okay? In some places, they say it should be 1.2, but we don't have to be that accurate. So remember either Winter's formula or this. In metabolic alkalosis, opposite thing happens. So there you have to use this equation. Expected PCO2 equals normal PCO2 plus 0.7 times increase in bicarbonate. Remember this. This is easier. Expected PCO2 is 15 plus bicarbonate. So in other words, expected PCO2 is 25 plus 15 is 40. That's normal. And that works here too in metabolic acidosis. 15 plus bicarbonate. So in respiratory disorder, in acute respiratory acidosis or alkalosis, for every 10 change in PCO2, bicarbonate changes by 0.1. So in other words, if, if the PCO2 goes up from 40 to 50, you expect the bicarbonate to go up by 1. But if it is a chronic respiratory disorder, if the PCO2 goes up by 10, bicarbonate will go up by 4. We see this in chronic carbon dioxide retainers, like in COPD. You will see that their bicarbonate level is always high. Jumping to anion gap metabolic acidosis, because whenever you see metabolic acidosis, you want to check the anion gap. So if the anion gap is broad, then these are the things. And if the anion gap is not broad, then it is non-anion gap metabolic acidosis. So the old acronym used to be MUD files. M stands for method, U for uremia, D for DKA, propylene glycol, INH, lactic acidosis, ethylene glycol, and salicylate. More recently, a colleague of mine, Ankit Mehta, and Dr. Emmett, who is a big name in the field of acid base, he came up with a new acronym called GOLDMARK. That is glycols, oxoproline, which is a metabolite of acetaminophen, lactic acid, D-lactic acid, methanol, aspirin, renal failure, ketones. So basically, he added oxoproline and removed the INH. In parts of the world where tuberculosis is more endemic, you may want to use the old one but add acetaminophen. Now, next thing is if the anion gap is broad, you want to look at the osmolar gap. Main role of osmolar gap is it's a quick test. Here for us, ethylene glycol and methanol level takes, even if we ask for urgent, it takes 1 day or more. And we can't wait that long. But osmolar gap is something that we can get from our lab. So what you want to ask the lab is measure the osmolarity. For us, when we get the printout of regular electrolytes, we get calculated osmolarity. But you want the measured osmolarity. And if the difference is more than 10, it's abnormal. And if it is more than 10, you have to suspect ethylene glycol and methanol toxicity. These two conditions also increase the osmolar gap, but decay is not that difficult to diagnose. Alcoholic ketoacidosis is not that difficult to diagnose. You see down here, high osmolar gap without metabolic acidosis. So unless alcohol toxicity causes ketoacidosis, you don't get metabolic acidosis in alcohol toxicity. Isopropyl alcohol toxicity is the other one that increases osmolar gap and does not increase the anion gap, or it doesn't cause metabolic acidosis. Same thing with mannitol. Isopropyl alcohol toxicity is one situation where you get ketone bodies, but you don't get ketoacids. So that's because isopropyl alcohol is metabolized into acetone. Acetone is a ketone body, but it's not an acid. Unlike in regular, say, diabetic ketoacidosis, you get acetoacetic acid, beta hydroxybutyric acid, and acetone. So these are acids, so you get acidosis, and they're unmeasured anions. So you get anion gap metabolic acidosis. So coming back to this, I'll go to the next step. So, but try to make it a habit. Always look at the pH. If the pH is low, they have acidosis as the main abnormality. And then look at the PCO2 and bicarbonate. If the pH is high, the main disorder is going to be alkalosis. And then look at the PCO2 and bicarbonate to see whether it's respiratory or metabolic. So if they have metabolic acidosis, then you have to diverge from here to look for anion gap. But for all the rest, this is what you have to do. So in acidosis, here I put 7.34. If you want to keep it simple, keep it at 7.4. So if the pH is less than that, look at the bicarbonate. If it is less than 24, it's primary metabolic acidosis. Then look at the anion gap. And if the anion gap is same as the change in bicarbonate, then so look at to the left of your panel, you will see pure AGMA. What I've done there is, so if anion gap goes up certain proportion, bicarbonate should go down the same amount. In other words, if anion gap goes up by 10, bicarbonate should come down by 10. Anion gap goes from 10 to 20, bicarbonate would come down from 24 to 14. Similarly, PCO2 also will go down by 10. So this is pure anion gap metabolic acidosis. If you go down in that panel to your left, if anion gap goes up, but bicarbonate goes down more than that. Say if anion gap goes up by 10, from 10 to 20, and bicarbonate, instead of going down from 24 to 14, say it goes down to 10. So that means it went down by 10 because of the anion gap, and it went down by another 4 because of non-anion gap metabolic acidosis. So this is a mixed anion gap and non-anion gap metabolic acidosis. The middle panel, the lower panel in the middle panels, anion say goes up by 10, but bicarbonate comes down by 5. So anion gap goes from 10 to 20. Bicarbonate should have come down from 24 to 14, but say bicarbonate is 19. That means anion gap dropped the bicarbonate from 24 to 14, and something else increased from 14 to 19. That is a metabolic alkalosis. So that's a combination of anion gap metabolic acidosis and metabolic alkalosis. Let's look at the other mixed disorders. So in pure metabolic acidosis, if bicarbonate goes down, now look at the panel on your right. If the bicarbonate goes down by 10, you expect the PCO2 to go down by 10. So if the bicarbonate went from 24 to 14, you expect the PCO to go down from 40 to 30. So that is pure metabolic acidosis with the right amount of respiratory compensation. Supposing instead of PCO2 going down from 40 to 30, it went to 25. That means you expected the PCO2 to go down by 10 as a compensation, and something else reduced PCO2 from say 30 to 25. That means there is a metabolic acidosis and another process reducing the PCO2 from 30 to 25. That's respiratory alkalosis. So this is mixed metabolic acidosis and respiratory alkalosis. Supposing bicarbonate went down from 24 to 14, you were expecting PCO2 to go down from 40 to 30. Instead, PCO2 is 35. That means the metabolic acidosis that led the bicarbonate from 24 to 14 dropped the PCO2 from 40 to 30, but something else increased the PCO2 from 30 to 35. So when does the PCO2 go up? That is respiratory acidosis, right? So patient has metabolic acidosis and respiratory acidosis. This is not a good sign. If somebody is septic with metabolic acidosis, now they start retaining PCO2. That means they are getting tired of breathing, and that's the time to intubate this patient. This is a longer explanation of same thing I explained now. So I'll kind of skip it since we lost time. But always look at the pH first, and wherever the pH, whichever direction pH is in, that is the main process. So if the pH is acidic, acidosis will be the main process. If the pH is alkaline, alkalosis will be the main process. And then look at the PCO2 and bicarbonate. Bicarbonate reflects metabolic side, PCO2 reflects the respiratory side. Only thing you should remember is when you do mixed disorder, remember that respiratory acidosis and respiratory alkalosis cannot happen together because you can't breathe fast and slow at the same time, isn't it? Lloyd, you will remember that.
Yes, yes. Thank you.
So these are some of the common combinations that you will see. This not only helps in clinical medicine, but also helps in writing exams. So these two pages are common situations. And after that, I'll go through some of the clinical scenarios. So in pneumonia, initially, patient will be breathing hard, getting rid of PCO2. So they get respiratory alkalosis. And if they become septic, if there's lactic acidosis, then they get anion gap metabolic acidosis and lactic acidosis. Then if they get really sick, they get tired of breathing, and now they start retaining PCO2, so they get respiratory acidosis. So in somebody with pneumonia, respiratory acidosis and anion gap are not good signs. If they have just respiratory alkalosis, that is fine. That just means they are hyperventilating. Same thing with pulmonary embolism. Initially, they hyperventilate, so they get respiratory alkalosis, and which is okay, and it's a clue sometimes to the diagnosis of pulmonary embolism. But if you find respiratory acidosis in PE, that means they are getting tired of breathing. They need some help, either by PAP or intubation. These are the patients who need to be managed in the intensive care unit. Sepsis again, sepsis and pneumonia kind of work similar. Initially, they hyperventilate, they get lactic acidosis, causing anion gap metabolic acidosis. And if they get sicker, they get tired of breathing and start retaining PCO2, respiratory acidosis. Decay is interesting. Diabetic ketoacidosis, you get multiple disorders here. You get anion gap metabolic acidosis from ketone body. You get non-ion gap metabolic acidosis later on during treatment. Once you give a lot of IV fluids, once you give a lot of sodium chloride, sometimes they get anion gap metabolic acidosis just from dilution of blood. You see this in people who have had CPR and large amount of normal saline. Next thing you check, they will have non-ion gap metabolic acidosis. You see same thing in DKA. But in DKA, you also get non-anion gap metabolic acidosis because of urinary loss of bicarbonate. If they're vomiting, they vomit acid and they develop metabolic alkalosis. In end-stage renal disease, you can get both anion gap and non-anion gap. And if they're vomiting, they'll get metabolic alkalosis. In anxiety, they hyperventilate, get rid of PCO2, causing respiratory alkalosis. In vomiting, I have one or two more slides on vomiting as to how it causes metabolic alkalosis. It's not just from throwing up the vomiting acid. It is also because it works through the kidneys, um, the increase in the aldosterone levels, and that causes loss or secretion of hydrogen ions in the distal tubule. In diarrhea, they lose bicarbonate in the stool, causing non-anion gap metabolic acidosis. Diabetics with like stable diabetics in the office, if they have low bicarbonate and high potassium, that is type 4 RTA. Aspirin overdose causes primary respiratory alkalosis because of hyperventilation. They get metabolic acidosis because salicylic acid is a unmeasured anion, and they get metabolic alkalosis later on. In myasthenia gravis, they get tired of breathing, so they retain PCO2, causing respiratory acidosis. In chronic obstructive pulmonary disease, they get chronic respiratory acidosis, and like I told you earlier, they have time to compensate. So they have metabolic compensation. So PCO2 goes up by 4 for every 10 millimeter rise in PCO. Sorry, bicarbonate goes up by 4 for every 10 millimeter mercury rise in PCO2. Loop diuretics and thiazides cause alkalosis. Carbonic anhydrase inhibitors cause metabolic acidosis. Okay, now the interesting part. So you have a patient with pneumonia. So I'll give you two scenarios. Scenario one is breathing at 24 per minute, pH is 7.45, PCO2 is 30, bicarbonate is 25, anion gap is 10. So in other words, you have normal anion gap. So let's start from pH. pH is 7.45. So it's more than 7.4. So patient is alkalemic. So main process has to be alkalosis. Now you look at the PCO2 and bicarbonate. PCO2 is lower than 40. Bicarbonate is 25. So PCO2 is lower by, so I'm sorry, I made a mistake here. PCO2 should be 23. Okay. Sorry, the bicarbonate should be 23. So PCO2 is 30. So it dropped by 10 from 40 to 30. And appropriate compensation would be, because it's acute scenario, bicarbonate would come down by 1. So this is not 25, it should be 23. Anion gap is 10. So this is pure metabolic, respiratory alkalosis from hyperventilation. You have another patient, so you have another patient with pneumonia, breathing at 12, this is acidemic, pH is 7.3, less than 7.4. Bicarbonate is 14, so patient has metabolic acidosis. So the bicarbonate came down from normal is 24, it came down by 10. Anion gap is 20, normal anion gap is 10, so anion gap went up by 10. So this is pure anion gap metabolic acidosis so far. Now PCO2 is 40. When the bicarbonate went down by 10, you expected the PCO2 to come down by 10. You expected the PCO2 to come down from 40 to 30. But this patient is something else is increasing PCO2 from 30 to 40. So this is normal PCO2, it's deceiving, but this patient has respiratory acidosis. So in other words, so this is the first patient, pure metabolic alkalosis from rapid breathing. This is the second scenario where bicarbonate went down. Look at the middle panel. So you have acidemia, so metabolic acidosis because bicarbonate is 14. And the anion gap is 20, normal is 10. So you have anion gap metabolic acidosis. So the change in anion gap is same change in bicarbonate. In other words, bicarbonate went by, so anion gap went up by 10, bicarbonate went down by 10. So it's pure anion gap metabolic acidosis. There is no non-anion gap metabolic acidosis, no metabolic alkalosis. But we look at the respiratory compensation. Bicarbonate went down by 10. Expected PCO2 by Winter's formula would have been 14 plus 14 times 1.5 is 21 plus 8 is 29 plus or minus 2. Or if you want to use the simpler way of Dr. Halperin, bicarbonate went down by 10. You expect the PCO2 to go down by 10. So bicarbonate is 14. You expected the PCO2 to be 30, but it's 40. So that's why there is respiratory acidosis. That is trouble. In patient with pneumonia, if they have anion gap, it's trouble. If they have respiratory acidosis, it's trouble. That means these patients are, one patient is septic, second patient is getting tired of breathing. So this patient needs to be moved to intensive care unit and at least go on BiPAP, possibly get intubated. Generally in pneumonia, which takes longer than 1 day to get better, I prefer intubation rather than putting them on BiPAP machine. But COVID has taught us to learn with minimum things. So do what your resources allow you to do. 23-year-old type 1 diabetes, ran out of insulin, feeling weak, lost 11 pounds of weight in 1 month. Respiratory rate is 24. One thing I ask you to do is when somebody is sick, count the respiratory rate yourself. It's very valuable. In the hospital, many times, at least the hospital I go to, everybody breathes at 20 or 18. And um, this is one of the very valuable bedside vital signs that is extremely helpful. So 24 is fast. Mucous membrane is dry. You see the patient has also lost 11 pounds of weight over a short period of time. So patient is volume depleted, breathing fast, hyperglycemic, blood sugar is 800, sodium is 144, potassium is 6, chloride is 110, bicarbonate is 10. Hospital now gas machine. Okay, so the blood gas is stressed a lot by acid-base experts. It's a good thing, but if you are in a small hospital, if you don't have blood gas machine, you don't have it. But every hospital has the ability to measure electrolytes. So you saw this electrolytes in a hyperglycemic patient, and bicarbonate is 10, and the anion gap is 140 minus 110, that is 34, minus 10 is 24. So anion gap is 24, normal anion gap is 10. And the bicarbonate, the patient at least has metabolic acidosis with anion gap. He's breathing fast, could have respiratory acidosis. I will not know till I do the blood gas, but that's okay. So far, what I know is anion gap is 24, change in anion gap is 14, change in bicarbonate is 14. So there is no non-anion gap metabolic acidosis and no metabolic alkalosis. So this is pure decay. Urine has ketone bodies. You can measure the beta hydroxybutyric acid. So this is primary anion gap metabolic acidosis. Okay. Same patient, the bicarbonate is low at 20. So there is at least metabolic acidosis. Okay, so the same patient, but bicarbonate is 20, anion gap is 24, change in anion gap is 14. That means I was expecting bicarbonate to be 24 minus 14 is 10, but this patient has, sorry, I think I mistyped here. Okay, so the bicarbonate is 20 instead of being 10. So anion gap is 14, bicarbonate is 20 instead of being 10. So some other process is increasing the bicarbonate from 10 to 20. So here, look at the top of the slide, patient is vomiting. Patient is vomiting, bicarbonate is higher than where it should be. So that is metabolic alkalosis. So this patient has anion gap metabolic acidosis and metabolic alkalosis. So same patient, supposing blood pressure is 90 over 60, you have already given 4 liters of normal saline. And now I'll give you two scenarios. Look at the bottom 3 lines of the slide. Scenario 1, lactic acid is 7, beta hydroxybutyric acid is 7. And remember, anion gap is 14. So anion gap of 14 is contributed by beta hydroxybutyric acid and lactic acid. Second scenario, all the anion gap is contributed to by beta hydroxybutyric acid. So in the first scenario, you can just focus on the last 4 lines. First scenario where anion gap increased by 14, so anion gap is 24. Bicarbonate dropped to 14, that is it dropped by 10. So lactic acid level is 7, beta hydroxybutyric acid is 7. So this patient has TKA and lactic acidosis, could be septic. That is the reason blood pressure has not come up in spite of giving that much of fluid. So this patient needs pressors. On the other hand, the second scenario, similar scenario, anion gap is 14. Change in bicarbonate is 14. Now, all the anion gap is contributed to by beta hydroxybutyric acid of 14. So this is pure decay. So this patient just needs more insulin and maybe more fluids. So this is the value of anion gap. It's very, very important, irrespective of whether you do blood gas or not. It's very helpful. Okay, now same patient, you started the patient on insulin drip, you gave a lot of volume, and 8 hours later, blood sugar is close to normal, 140, sodium is 140, potassium 4, chloride 110, bicarbonate 20, anion gap 10. So the anion gap disappeared. That means there are no more ketone bodies in the blood, but bicarbonate is still low. So what do we have? We have a non-anion gap metabolic acidosis here. And you commonly encounter this during the treatment of diabetic ketoacidosis. So there is no anion gap. Look at the last 3 lines. No anion gap anymore, but there is metabolic acidosis with no anion gap, which is new now. There is no metabolic alkalosis. So there is a non-anion gap metabolic acidosis during the treatment of DKA. So this is believed to be just partly from dilution, partly from dilution because of giving a lot of chloride-rich fluid like normal saline, and partly because of loss of ketone bodies in the urine, which are source of bicarbonate as well. Now switching gears, another patient. Diabetic, now it's type 2 diabetes on oral glipizide and dapagliflozin or empagliflozin, whichever you have access to, comes feeling weak, no history of tuberculosis, breathing fast, mucous membrane is dry, blood sugar is 180, sodium 144, potassium 5, chloride 110, bicarbonate 10, creatinine 1.1. So what is the acid-base disorder? Again, I'm in the same rural hospital. I don't have blood gas. So this is a diabetic. Blood sugar is not so bad, but look at the anion gap. 144 sodium, chloride 110. So that makes it 34. 34 minus bicarbonate of 10. So anion gap is 24 in a type 2 diabetic on oral drugs. So whenever you see anion gap in a diabetic, you suspect ketoacidosis. But this is a type 2 diabetic, not on insulin. So, but there is metabolic acidosis, we know that. And there is anion gap because there is anion gap. So what is the cause of anion gap acidosis? So we looked at the lactic acid level, 0.2, salicylates were negative, acetaminophen is negative, osmolar gap is normal. That's why I'm not suspecting methanol or ethylene glycol. What's missing? So DKA was not thought of because of euglycemia, but this patient actually has euglycemic DKA, which is one of the kind of side effects of dapagliflozin or SGLTI. So SGLTI cause glycosuria, so they don't allow the glucose to go up that much, but and they can cause delayed diagnosis of diabetic ketoacidosis. One of the known side effects of treating with SGLTI. How does vomiting cause metabolic alkalosis? So the conventional and the easy logic is you're vomiting acid, so you should have metabolic alkalosis. That's the easy part. But they also get volume contraction and increasing in the angiotensin 2 and aldosterone, and it causes more hydrogen secretion in the distal tubule, causing metabolic alkalosis. So this is the mechanism of contraction metabolic alkalosis. In pregnant people with hyperemesis gravidarum, they get loss of hydrochloric acid, volume depletion, metabolic alkalosis, hypokalemia, hypochloremia, low urine chloride with normals. Okay, This is another metabolic acidosis patient, 70-year-old lady with severe osteoarthritis. This is somebody I saw recently. The age and some numbers I made them up, but I did see the patient with this problem. So this patient with the severe osteoarthritis was taking a lot of, in the US now, it's hard to get narcotics. So a lot of people take a lot of non-steroidals and acetaminophen, and also, acetaminophen, salicylates, and other non-steroidals. So this patient actually was feeling weak, but blood pressure was okay. She was looking okay. She was eulemic, afebrile, not septic, but there was an anion gap, and there was no osmolar gap. Patient was euglycemic, non-diabetic. Creatinine is normal. So no decay. Creatinine is normal. No uremia. Lactic acid is normal. And salicylate is normal. Beta hydroxybutyric acid is negative. We even did methanol level, ethylene glycol, even the osmolar gap was normal. We kind of went through these mud piles, the panel on your right. So there are no methanol, no uremia, no DKA, no propylene glycol is administered as a vehicle in somebody who is already in the hospital with some medicines. Patient has no tuberculosis and not taking anti-TB medicines, no lactic acidosis, no ethylene glycol, no salicylate. So we're kind of scratching our head because I really went through this and all of them were not there and patient still had an gas. So then we checked the acetaminophen level, which is paracetamol. Paracetamol level was 22 and I called the nurse. He said, I sent the acetaminophen, is it back? She said, yeah, it is back, but it is normal. So she said normal because the lab says 0 to 30 is safe. Some say 0 to 25. Our lab says 0 to 30 is safe. Or so. So it didn't come as a red flag. It didn't come as abnormal. I said, what do you mean normal? Normally, we don't have acetaminophen level in the blood, acetaminophen in the blood. So it ended up being 22. And this patient was taking like 4 grams of acetaminophen every day. And, now we use the Goldmark acronym and we found this acetaminophen there hiding. So there is merit to using both acronyms, both Mudpiles and Goldmark. We are running out of time. Lloyd, is it okay to extend a few minutes?
No problem. No problem.
Yeah.
No problem. Please go on. Please go on. Thank you.
So this is a 15-year-old boy who is brought to the emergency room by his foster mother, who states that when she got home from work, she noticed he was acting very strange and had slurred speech, appeared confused. Fundoscopy exam, hyperemia. If you find this, or if you are an exam taker, if you find this, it means something. Okay, we'll come to that. So sodium is 135, potassium is 5, chloride is 105, bicarbonate is 8. So bicarbonate is low. There is metabolic acidosis. Creatinine is 1.3, slightly on the high side, but not high enough to cause metabolic acidosis. Glucose is normal. Patient is not a non-diabetic. So unlikely. Before that, let's go to anion gap. 135 minus 105. So that is 30 minus 8. So the anion gap is 22. So this patient has a anion gap metabolic acidosis, even without blood gas. But we did the blood gas. PCO2 is 22. So bicarbonate is 8. That is the bicarbonate dropped by 16 and the PCO2 dropped by 18. They're not that different. So the compensation is reasonable. If you want to be purist, you can call it respiratory alkalosis by a small amount, but let's not worry about that. So the osmolarity, measured osmolarity was 320, calculated osmolarity, this is the equation. Sodium times 2, B1 divided by 2.8, glucose divided by 18. So that comes to 271. So the 271 was the calculated osmolarity. Measured osmolarity was 320. So osmolar gap is high. So whenever osmolar gap is high, think of methanol and ethylene glycol. When you see hyperemia of the optic disc, always think of methanol toxicity. So what is the next step? Gastric lavage, N-acetylcysteine and charcoal, naltrexone, thiamine, bicarbonate, hemodialysis, fomepizole. Wait for serum levels of salicylate, methanol, or ethylene glycol. Wait for methanol and ethylene glycol is always the wrong answer. If you're suspecting methanol toxicity, you need to either start them on fomepizole initially till hemodialysis is arranged. And so the hemodialysis and fomepizole is the correct answer here. You're dealing with a young boy with anion gap metabolic acidosis with osmolar gap, and we don't see any other obvious causes of metabolic acidosis. You're suspecting methanol toxicity and you want to treat it right away. I will skip this. I'll just mention the, but if you find somebody with metformin toxicity, treatment is hemodialysis. If you find somebody with salicylate toxicity, again, treatment is dialysis. Acetaminophen could do dialysis, charcoal after giving N-acetylcysteine, and ethylene glycol and methanol, you give dialysis. And initially, fomepizole, or if you don't have fomepizole, you can give ethanol infusion. So this is another patient, 22 years old, African American female, brought to the emergency room after her sister found her drowsy next to an empty bottle of aspirin. So I already gave you the answer. So this is an interesting scenario, aspirin-related toxicities. So that's why I put this case. Sodium 138, potassium 3.9, chloride 97, bicarbonate is 15. So patient has metabolic acidosis here, and the anion gap is 26. Normal is 10. You did the blood gas, pH is 7.48. So patient has mainly alkalemia. So metabolic acidosis is not the main disease. Okay, patient has alkalemia or alkalosis, and PCO2 is 21. So normal is 40. So patient has primary respiratory alkalosis. Patient has metabolic acidosis with the anion gap of 26. So we have at least mixed primary respiratory alkalosis and anion gap metabolic acidosis. So this is classic salicylate toxicity where you get metabolic respiratory alkalosis, lactic acidosis, ketoacidosis. Salicylates actually block the Krebs cycle. So you get a lot of different acids. Like it gets diverted to lactic acid cycle, but if you were to measure like citric acid, alpha ketoglutric, everything will be up. So that's why their lactic acid level will not be same as. So whenever you see alkaline pH, low PCO2, wide anion gap, think of aspirin tox. So coming back to summarize the talk, this is what I want you to remember, this and next slide. Always look at the pH first. If the pH is high, primary abnormality is alkalosis. If the pH is low, primary abnormality acidosis. And if the primary abnormality acidosis, look at the PCO2. If it is high, it's primary respiratory acidosis. If the PCO2 is low, it's primary metabolic acidosis. And compensation will be, if the respiratory disorder is the primary abnormality, compensatory mechanism will be the other one. And look at the compensation. In metabolic acidosis, you can use the Winter's formula or you can use the simplified version that I told you. So if PCO2 goes up by 10, bicarbonate goes up by 10, PCO2 comes down by 10. Okay. And so in metabolic acidosis, always look at the anion gap. If change in anion gap is same as change in bicarbonate, then it's pure anion gap metabolic acidosis. If the change in the anion gap, if the bicarbonate drops more than change in anion gap, that means there is a, in addition to anion gap metabolic acidosis, there is a non-anion gap metabolic acidosis. On the other hand, if the bicarbonate change is less than the increase in anion gap, that means there is a metabolic alkalosis in addition to anion gap metabolic acidosis. So Winter's formula is expected PCO2 equals 1.5 times bicarbonate plus 8 plus or minus 2. And so if the PCO2 is more than expected, that means there is a additional respiratory acidosis. If the PCO2 is less than expected, that means there is a additional respiratory alkalosis. In other words, if the bicarbonate drops by 10, you expect the PCO to drop from 40 to 30. Instead, if the PCO2 is 20, that means there is additional respiratory alkalosis. And if the PCO2 is, say, instead of being dropping from 40 to 30, if it goes to 38, that means there is a additional respiratory acidosis. And that is the end of my presentation. I'm sorry I went over time a little bit, and we are open to questions. And thank you again, Lloyd, Dr. Amirali, Dr. Okech, and all the rest of you.
Thank you, Dr. Shetty, for that enlightening talk. And no, you are actually right on time, so please do not apologize for that. The talk was fairly enlightening, and I think it is important that once you're dealing with an acid-base disorder, I mean, your approach is absolutely fantastic. I mean, step by step, and the flow charts were just amazing. I think if you follow that, you can't go wrong. And it's very important that once you identify the disorder, you should see if there is adequate compensation or not. And once you do that, then I think you probably have already clinched the disorder. So I think thank you again for that. It was fairly informative, and I see there are quite a few people asking for the presentation. We will do that. We will share it with all of you once the talk is over, and we'll also upload this talk on YouTube in the next few weeks. So not sure if there are any questions. If there are, please do ask. Otherwise, I can ask Dr. Lloyd for his comments. Dr. Yuri.
Thanks very much. This is a phenomenal talk, and the very simplified step-by-step approach. And those, especially those cases, are very, very interesting, and step-by-step approach. Now, I have a special request to make. Can we have 4 sessions next year? Where we can actually discuss, the various scenarios just as case-based scenarios. Slowly, maybe 5 or 6 cases. If you could spend little time with us, I'm sure you'll help us. Whatever possible. I'm not saying 4, even less is fine. But if in a quarter, one session in a quarter, just case based, where we don't have ABG and we have ABG, right? So that sort of scenario, we'll be dealing with, diabetic ketoacidosis, septicemia, these sort of things. Then at your paracetamol, acetaminophen poisoning, what you see and what you expect, and then what you get. So that sort of thing, just case-based scenario, case discussions. It will be really, really interesting, actually.
Sure, I'll be glad to.
Yeah. Thank you so much. And just to mention, Anup and myself are classmates. We did our internal medicine MEd together. Anup was a topper in the class, and always looked up to.
You
and
too.
No, that's very much true. Very much, so, and a very simple person, but high achiever. Worked in some of the big places, big people, and always accessible. So, and always helpful. And he's also actually a cancer survivor, has written a book, which we've actually not put in there, but written a beautiful book that I will actually post on. And always helpful, always ready to teach, a great teacher, in fact. Yeah. So thank you so much, Anup, and we expect you next year, please. Case-based scenarios, it will be really nice. Those cases are fantastic and great. Continuing to repeat the approach so people get the approach, just even without reading. That's the key, actually. So thank you so much, and I like your slides. If you can share them, I will put it across the board to everybody. That's much the goal today. Thanks, Anup. And today is the American Society of Nephrology, and actually Anup is in San Diego at the conference and has taken time off to actually talk to us. So very grateful, sir, Anup. Thank you so much. Thank you very, very much.